Hello students, I'm the OG Guru Dr. Punit Bhojani and welcome to the session. Now in this session we are going to discuss the 7 must-know concepts before your upcoming FMGE examination. Okay, and these are really going to be helpful to you and you can quickly see this is going to be a short video. You can see it at even 1.5x speed. Is going to be the best time which you will spend on the social media on today's date if you see the video. Okay, and two things we are going to discuss very important concepts in this video. You will get a lot of important knowledge and surely questions will be expected from this. I'm not going to discuss MCQs in this video because there's a separate video which is really being appreciated by all the students. I have created a video of hit list, the most important topics for your FMG exam, the list of important topics, and also very important MCQs are discussed in that separate video. So do check out that video also. And don't go to the FMG examination without knowing these concepts. Okay, you have to know these concepts and then you should definitely get MCQs from this topic is my guarantee. So don't go to FMG exam without knowing these concepts. And the annotated PPT of this would be available on the Telegram channel also. So let us begin the first important Swyer syndrome. Now many students have a confusion what exactly is the Swyer syndrome. So just 3 important points you should keep in mind. That point number 1, it is a pure gonadal dysgenesis. It is a pure gonadal dysgenesis. So, but the important point is that the karyotype when we do, you have to know it is 46XY. Okay, 46XY is the karyotype. But they are, when the patient is born, the genitalia look like a female. So they are read like female. So the external genitalia is of a female. External genitalia is a female. So therefore they will be read up as a girl child and majority of them will come to the OPD with primary amenorrhea. But the important point to be kept in mind is in Swyer syndrome that the uterus, it is gonadal dysgenesis, but the uterus is present. Okay, uterus is present. Okay, so it's like a boy XY but with uterus is present. Okay, so just remember these 3 points. 46XY, female external genitalia, so read up as a female, presenting with primary amenorrhea, but the uterus is present. And can you tell me one more condition? So this is your Swyer syndrome. Of course, this gonads needs to be removed, otherwise there's the risk of malignancy. Okay, so you need to give hormones to induce the puberty and the uterus is present so they can start getting menstruation. But the important point is that the karyotype is 46XY. Now can you tell me one more condition in which there is 46XY? Yes sir, the complete androgen insensitivity syndrome also, which is our third most important cause of primary amenorrhea. This is also 46XY. Okay, but then what is the important point to differentiation? Yes sir, here the uterus is absent. Is this understood to all of you? So when you have 46XY in your exam, sir, one thing is it could be CAIS if the uterus is absent. But one more 46XY relatively new because not routinely taught to you, and that is your Swyer syndrome. But in Swyer syndrome, the uterus is present. Okay. So both of them present to us with primary amenorrhea. Both of them are read up as female. They have got a normal female external genitalia. They'll be read up as a girl child. They'll be coming to the Gynaec OPD, but they are having karyotype of 46XY. They present to us with primary amenorrhea. But remember, uterus is present. When you do the karyotyping, you know it is 46XY. Sonography, uterus is present. CAIS, the important point is that the uterus is absent. Swyer syndrome, uterus is present. Okay, is this understood to all of you? So like this, we're going to give you pearls of wisdom. Short 7 concepts will be finishing in 15 minutes time and you will get lot of information. So this is a virgin MCQ likely to be coming in the upcoming examination. Moving on to the second important, yes, this again a confusion. Earliest to detect pregnancy versus earliest to detect live pregnancy. Now please understand, the urine pregnancy test The important word in the question will be this one word, LIVE. The LIVE, only this one word will change and the question answer will change. Options will remain the same. Okay, so please understand this, that the urine test, what we do, the urine pregnancy test, or 2 drops you put in the kit, okay, and you get the result. Okay, kabhi khushi kabhi gum. Why kabhi khushi kabhi gum? Because if you're planning pregnancy and you see 2 lines, happiness. But if it's an unplanned pregnancy, then shock. Okay, so kabhi khushi kabhi gum. Okay, so when you do that urine test, the urine pregnancy test becomes positive generally after missed periods. After missing the periods, after 1 or 2 or 3 days. Now the newer tests are becoming more and more accurate. They are becoming positive just 1 day after the missed period, or even on the 1 day after the missed period, or 2 days. Olden kits were available 3-4 days used to take. So UPT becomes positive, basically remember, after missed periods. But what is the urine pregnancy test detecting? Sir, it is detecting urinary HCG. But where will the HCG come before? Yes, HCG will come before in the patient's blood. So serum beta HCG. Serum beta HCG, if you do, serum beta HCG will become positive even before missed periods. Okay, keep this in mind. Before missed periods, even before missing the periods, the serum beta HCG becomes positive. Okay, and therefore that is the earliest to detect a pregnancy. So what is the answer? Earliest to detect pregnancy, serum beta HCG. Now how early? Please pay attention just for your reference, that if the implantation, okay, this is the day of ovulation, generally on the 14th day, okay, 28-day cycle, and all of us should know that when does the implantation take place? Sir, implantation takes place 6 days following fertilization. Okay, so after, F is for fertilization, O is ovulation. Okay, so around ovulation there will be fertilization, and 6 days after fertilization, that means roughly day 20 to day 21 of the cycle, is the implantation. And today the technology has become so advanced that on 21st day, if there is implantation, as early as 22nd or 23rd day, we can detect beta HCG in the blood. The serum beta HCG will start becoming positive on 22nd to even 23rd day of the cycle. That means even before, see, she has not even missed period. Here she got the period, here 28-day cycle. If she does not get periods here, then you say she has missed her periods. So urine test becomes positive after few days of missing the periods. But the serum beta HCG is positive even, yes, in all this period, the serum beta HCG will be positive. So what in the whole world to detect the pregnancy earliest? Serum beta HCG. But beta HCG positive only tells me pregnancy. It's somewhere in the body there is chorionic activity. Now, whether that pregnancy is inside the uterus, outside the uterus, one baby, live baby, all that I come to know only when I do ultrasonography. Why? Because for live pregnancy, what are we supposed to detect? Sir, we are supposed to detect the fetal cardiac activity. Thak, 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 thak on sonography screen. We should hear the baby's heartbeat. We should see the baby's heartbeat. Okay. So for earliest diagnosis of live pregnancy is by detecting fetal cardiac activity, and which is by transvaginal sonography. Yes, not only sonography, transvaginal before. Okay. So transvaginal sonography, that Doppler machine and stethoscope will pick up the heartbeat later on in pregnancy. Okay, but on ultrasonography and specifically transvaginal sonography, the fetal cardiac activity can be detected as early as 6 weeks, and now with a newer machine, even 5 weeks 5 days. Okay, so by 5 weeks 5 days or 6 weeks from LMP, we can say that it is a live pregnancy. Zinda home hai, baby says zinda home hai. Okay, so don't make a mistake. I repeat, if the question is earliest to detect pregnancy, urine test, serum beta HCG, sonography, mark serum beta HCG as the answer because it is positive even before the missed periods. Okay, so earliest to detect pregnancy, serum beta HCG. But when the question of live pregnancy is asked, sir, it is by demonstrating fetal cardiac activity, which is by transvaginal sonography as early as around 5 weeks, 5 days or 6 weeks is what can get the heartbeat. Okay, so that is a very important concept. Don't get it wrong and read the question correctly. Moving on to the next important concept. Yes, sir. Definitely short question for Down syndrome trisomy 21 detection. There are some screening tests, there are some confirmatory tests. Now students have a lot of confusion. What is the dual marker test, triple marker test, quadruple marker test? All that, how are they performed? Wherever I ask the student, all over India, when I ask the student, okay, how will you do a triple marker test? How will you do a double marker test? How will you do a quadruple marker test? I get the answer as some will say amniocentesis, some will say chorionic villus sampling. Wrong, kachra, dustbin. Okay, please remember that all the dual marker test or the triple marker test or the quadruple marker test are done on maternal serum. It is a simple blood test. It is a simple blood test done on the mother's blood. Is this understood to all of you? So dual marker test or double marker, triple marker, quadruple marker are done. They are the screening test. They are the screening test done on maternal serum. Okay. By the way, screening can also be done with the help of ultrasonography, which also I'll tell you, and that is by the NT scan. Okay. But mainly screening is on maternal serum, and that is the dual marker, triple marker, quadruple marker test. Those are the screening tests. But what is the confirmatory test in the whole world? If I want to confirm whether baby is having trisomy 21 or not, that is by, yes sir, you, me, we all have 46 chromosome. I want to detect whether the baby is having 47 chromosome. So the confirmatory test is by doing karyotyping. Is this understood? And how to get the sample for karyotyping? Yes sir, either chorionic villus sampling or amniocentesis. So these are techniques. Chorionic villus sampling and amniocentesis are techniques to get the sample, and then from that sample you will do karyotyping. Okay, so don't make a confusion that the confirmatory test is by karyotyping, which I can do by CVS or amniocentesis techniques. Okay, and dual marker test, triple marker test, quadruple marker test are screening tests done on maternal serum or maternal blood. By the way, dual marker test is going to be done in the first trimester, and triple marker, quadruple marker test are done in the second trimester. Definitely a question is coming on this. Okay, triple marker, quadruple marker, second trimester, roughly around 16-18 weeks. Okay, so please keep this in mind. Don't confuse the two tests, screening test versus confirmatory test. Moving on to the next important topic, and yes, antepartum hemorrhage. Surely the question comes on this. Now keep in mind that whenever antepartum hemorrhage means while the baby is inside the uterus, the bleeding starts. Okay, so here the common part will be that the patient will come to the OPD with bleeding in the third trimester, bleeding in T3. Third T3 is my short form for third trimester. Okay, so bleeding in T3. Now here you need to keep in mind two things. Okay, it's either it could be placenta previa, or it could be abruption. And what is the main difference? Very popular thing. It's a placenta previa is mainly going to be a painless bleeding. It is going to be a painless bleeding, and the uterus is generally going to be relaxed. Whereas sir, abruption is always painful. Abruption is painful, and the uterus, because of blood inside the uterus, the uterine tone, there is increase in the uterine tone, so it is painful, and the uterus is increase in the uterine tone, you will feel uterus hard. And one more important point, if in case you read the word tonically contracted uterus, in case if you read the word tonically contracted uterus, you can blindly go for marking abruption. Okay, so increase in the uterine tone, painful bleeding. So when they say patient has come to us with episode of painful bleeding, increased uterine tone, contractions, and the uterus is tonically contracted, that is abruption. Versus if they say painless bleeding and the uterus is relaxed, that is placenta previa. So don't make a mistake in this. And one more important point you need to keep in mind is placenta previa, we can wait and watch. Abruption, never wait and watch. Placenta previa, we can wait and watch depending on the conditions, and abruption, never wait and watch. So this is again a very important thing. The common part will be there will be bleeding in the third trimester. So keep this concept in mind. Okay, moving on to the next. Yes, very common thing, eclampsia, what next? So here again two types of questions could be asked to you. So eclampsia is presence of convulsion in a patient of pre-eclampsia. Now very quickly, in a Hindi movie or any other movie you might have seen that doctor comes out of the labor ward and says कि हम माँ और बच्चे में से किसी एक को बचा सकते हैं. Okay, and doctor will say either I can save the mother or save the baby. Then whom to save? Okay, save the mother, save the baby. Indian government, save the tiger, save the cheetah. We doctors will say save the doctor first. Okay, so point number one important is that mother is always first. Mother is more important. Why I am telling you this is that if the eclampsia question paper given at whatever weeks, let the patient be 24 weeks, 26 weeks, 28 weeks, 32 weeks, the answer will not change. When there is eclampsia, immediately what next? Immediately what next is we are going to give magnesium sulfate. Okay, magnesium sulfate is to stop the convulsion, prevent further convulsion. But magnesium sulfate is not the definitive treatment. So please read the question. If the question is patient is having eclamptic convulsion, what immediately I will do next? So sir, immediately what you do next is magnesium sulfate. But then after giving magnesium sulfate, can I wait and watch? Never. Can I wait and watch? Never. After giving magnesium sulfate, yes, remember what if they ask you the question, what is the definitive treatment? Okay, the question is suppose that in a patient of eclampsia, the definitive treatment is, and suppose the question is option labetalol, magnesium sulfate, do time pass, and delivery. Anybody, what if these are the options? So labetalol, of course sir, I will give to control the blood pressure, but labetalol is not the definitive treatment. The important part is definitive treatment. Okay, so labetalol is not the definitive treatment. Of course magnesium sulfate will also be given, but magnesium sulfate is only to stop the convulsion, prevent further convulsion. Please don't do time pass, you'll have to go to jail. In a patient of eclampsia, if you do time pass, you'll have to go to jail. So please don't do time pass. Yes sir, delivery is the definitive treatment. And irrespective, why I told you that doctor and patient story, that we don't give such option to the relatives that you tell me whom to save. No, always mother first. So magnesium sulfate, and then I have to proceed for the delivery. Delivery is the definitive treatment. So please understand this, delivery is the definitive treatment. And important words is we will go for delivery. Irrespective of weeks of gestation. That means let the patient be 24 weeks, 26 weeks. Yes sir, 26 weeks or 24 weeks baby will not survive. Fine, but you can't wait. You can never wait and watch after giving magnesium sulfate. The delivery has to be done irrespective of weeks of gestation or gestational age. So please keep this in mind. Whatever may be the weeks of gestation, answer does not change. So if they ask you next immediately what will I do? Magnesium sulfate, but the and followed by delivery. But if they ask you definitive treatment, delivery is the definitive treatment. So keep this concept in mind. Never wait and watch. Never WW. Okay. Moving on to the next important, yes, please keep in mind, students, surely I'm expecting this question. Primary amenorrhea, the definition has changed and you surely need to keep in mind. So very quickly, the old definition was, please understand this, that if the axillary hair, pubic hair, breast development is present, then you call this as secondary sexual characters. What is secondary sexual characters? SSC. SSC is my short form for secondary sexual characters. That means that is development of breast and axillary and pubic hair. Okay, so when I see a girl in the OPD, and if secondary sexual characters are absent, that means, sir, there is no breast development, there is no axillary pubic hair, and if the girl has primary amenorrhea, means never got menses. Okay, primary amenorrhea means patient has never got menses. Okay, never. Okay, patient has never got menses, but till what age? That is the important point. Never got menses or absence of menses. So if the secondary sexual characters are absent and the old, okay, so first I'm telling you the old, remember the figures 14 and 16. So if the girl reaches 14 years of age, and if secondary sexual characters are absent, then you label her as primary amenorrhea. But if secondary sexual characters are present, that means her breast is there, axillary pubic hair is there, and we can wait. We wait for 2 more years, and by 16 years also, if there is no menses, if there's absence of menses, then you label the girl. So absence of menses. Absence of menses is a common thing in the definition. Absence of menses. In absence of secondary sexual characters, no menses till the age of 14 years. And in presence of secondary sexual characters, no menses till the age of 16 years. But this, my dear student, is the old criteria, and we will not keep this in mind. And now this has changed. This 14 and 16 has changed. And the new thing what you need to keep in mind is that this has been decreased by 1 years. This 14 has become 13 years, and this 16 has now become 15 years. So please don't make a mistake in this. And therefore, the newer definition of primary amenorrhea is that, sir, when the patient has not got her menses by the age of 13 years, in absence of secondary sexual characters, you call her primary amenorrhea. And when the girl has reached 15 years of age and secondary sexual characters are present, breast, axillary pubic hair are present, but she has reached 15 years and still she has not got her periods. Absence of menses by the age of 15 years in presence of secondary sexual characters. Okay, first check the secondary sexual characters and then present or absent, and then decide, and then accordingly mark the answer. Just remember two numbers, 13 and 15 are the new numbers, two new numbers to be kept in mind. 14, 16 are the old criteria. Don't remember that. Okay. And moving on to the last pearl of wisdom and last important gyan. Yes, very, very important. What are the soft tissue markers? Soft tissue markers are signs which we get on ultrasonography for Down syndrome. So surely we need to know. Many students know only one, and that's why I'm going to teach you this. That's an increase in NT that everybody should know. What is this NT? Nuchal translucency. Okay, don't get confused. NT is nuchal translucency. Not nuchal fold thickness is also increased. That is separate. So that is increase in nuchal fold thickness. NT is nuchal translucency. Okay, so NT scan. So this is one. But what more important? Yes, this is how you do screening by USG. Okay, absent nasal bone. So keep in mind, absent nasal bone. So these are the two most important, and 3, 4 more important we need to keep in mind. Omphalocele, congenital diaphragmatic hernia, sometimes even single umbilical artery, and very, very important, please keep in mind, duodenal atresia. Okay, So duodenal atresia, your double bubble sign. Okay, duodenal atresia. Okay, short femur, short humerus. Okay, the long bones, short femur, short humerus. Okay, omphalocele, congenital diaphragmatic hernia. So all these are important soft tissue markers for Down syndrome on ultrasonography. Increase in nuchal translucency, absent nasal bone, duodenal atresia, short femur, short humerus, omphalocele, diaphragmatic hernia, and sometimes also remember your very important echogenic intracardiac focus. Okay, dilatation of the renal pelvic-calycial system. Dilatation of the renal pelvis is also there. That is called as renal pylectasis. Very, very difficult virgin MCQ. Renal pylectasis. Sometimes within the heart, you may get a echogenic focus. Echogenic intracardiac focus. Okay, and the last, sandal gap. Okay, sandal gap is what? So there's a gap between the great toe and the remaining toes. Okay, so baby's foot, if normally first toe, second, third, fourth, fifth, this is normal. Okay, this is normal. But what will be there in babies of Down syndrome? So the great toe will be like this, and then there'll be a gap, and second, third, fourth, fifth. Okay, so then you will see this gap between the great toe and the remaining digits. This is called as the sandal gap. So you need not remember the whole list. The most important ones I'm going to tell you: increase NT, definitely you should know; absent nasal bone, definitely you should know; duodenal atresia, these three also if you know, that is very good. Short femur and sandal gap between the great toe and the remaining toes of the foot, this is the sandal gap. Only keep this much in mind. And dilatation of renal pelvic system, echogenic intracardiac focus, even if you don't remember, that is okay. So these are our very, very important soft tissue markers of Down syndrome. Okay, so wishing you all the best for the upcoming exam. This 7 pearls of wisdom, or the 7 concepts, I'm sure are going to help you a lot. Do subscribe to the channel, and definitely also download the OGGURU app, and you can go in for the rapid revision course. It's really going to be beneficial for all of you. I'm always there to available to answer all your doubts, and please do see this video, and the annotated PDF will be available on the Telegram also. So do subscribe to the channel, tell all your friends, and wishing you all the best for the upcoming FMGE exam.